Welcome again to the second conference. And before I commence my presentation, I'd like to say that I am impressed by the presentation of Alexander Gusev. I got acquainted with him quite recently. We can see the three stages of the development of the healthcare system if we look at this from the holistic point of view. First of all, medicine based on the clinical thinking of a doctor, the first stage. Stage two, medicine-based healthcare system based on evidence-based medicine when we're talking about statistics and standardization. And stage number three, it was mentioned by Alexander, that's a digital healthcare based on big data and on the reduction of human involvement in terms of decision making, because a person is the source of the lesser efficacy, including clinical efficacy, economic efficacy, and the previous presentation also confirmed this. When we're talking about bringing science closer to medicine, digital medicine will make this process faster, objective, aimed at better use of the results of RWD. Just in a nutshell, what is the role of the Federal Anti-Monopoly Service on the medicines market? Let me just say what our organization is doing here. We are responsible for the development of competition on the medicines market. And of course, as for RWD, the process of registration, well, expert assessment and other things have an impact on the economic situation of pharmaceutical companies on the market. Sometimes there might be a wonderful hypothesis put forward in order to register a specific drug, but this hypothesis was not confirmed. The company goes bankrupt, and you can see that in this case, we need additional processes to confirm a hypothesis. So we always use our WD and our expert assessments when we carry out an investigation concerning this or that medicine. That's our first task. The second task is to assess the use of governmental resources like state purchase of specific drugs, etc. Our third goal is to participate in the pricing process as far as the pharmaceutical market is concerned. As for the pricing system, it is based on different indicators. Some of the indicators are directly linked to real world data and to the registration of drugs. So the Federal Anti-Monopoly Service is actively involved here. Now let me just raise specific problems that we as the Federal Anti-Monopoly Service see based on our current activities. I will give you some specific examples related to the current activities of the Federal Anti-Monopoly Service. But summing up, I should say that one of the major problems is the lack of algorithms in administering specific drugs, especially in Russian clinical guidelines. We can see that, unfortunately, the Ministry of Health is not trying to develop such algorithms in administration of drugs for specific indicators. And after the registration of the specific drug, sometimes it's difficult to take into account all the aspects related to the drug administration. Sometimes the ministry just ignores real world data. That's a real phenomenon that we see here. As for standardization and the use of real world data in the healthcare system at the level of the patient and at the level of a particular healthcare facility still leaves much to be desired. We're very concerned about it. And at the same time, we can see that there is the difference in the administration of one and the same drug in Russia and in other countries. Hopefully, we have access to international experience and practice. And when the Federal Anti-Monopoly Service conducts an investigation, we try to take into account the experience of international practice and compare it with the situation in Russia. This comparison gives us a lot of food for thought, and later I will provide specific examples, and often, well, we hear such explanations as, well, this just happened because we live in Russia and we're different from the rest of the world. Well, of course, we are talking about the scientific aspects here about standardization or verification of specific processes, and these processes should be based on international standards, not just on the standards of a particular country. Then the creation of specific lists of drugs that the government is going to pay for. And right now we can see that decisions are being taken not on real world data in many situations. Well, yes, there is a special registration assessment that takes place before the drug registration, but I think real world data should lie in the process of decision making. Right now, the process is quite the opposite, and we're also very concerned about it. Let me also give you some specific examples. That's what we are working on right now together with the Ministry of Health. We discuss these cases. Well, these are real cases. And if you look, for example, on the use of insulin Galargin, 300 international units per milliliter, well, you can see that there is a significant difference in the Russian clinical guidelines existing now and the new guidelines we are going to adopt. You can see the draft clinical guidelines, and on the other hand, we can make a comparison with NICE or NHS in the UK, and we can see that there are two drugs, well, that can be used for treatment of the same condition, but there is a difference in price. And you can see, as for international clinical practice, in the West, the aim is to improve the healthcare system of specific countries. In international clinical guidelines, we can see a lot of algorithms aimed at administering this insulin 300 international units in case of specific indications. This drug is aimed at burning sugar in blood, but since, well, these guidelines are different, international practice shows that the healthcare system uses RWD in order to develop an algorithm and to describe the process of the drug administration for specific conditions. And this drug, I'm not going to go into detail, can lead to the improvement of the healthcare system. In Russia, it's quite the opposite. It leads to the higher price. And in Russia, there is a situation when 78% of all purchases of the drug, all procurement of the drug, out of 100%, falls into this particular insulin, 300 international units per milliliter. In the West and in other countries, the same drug, because in the West, clinical guidelines are based on RWD, this share is only 25%. So you can see there is a principal difference in terms of administration of a specific drug. And of course, this has a negative impact on competition because this drug, 300 international units in the West, well, has just a 25% share of the market. And in Russia, it's 78% of share of the market. It's just a monopoly. And we can say that in terms of treating diabetes mellitus, the drugs in Russia are much more expensive, and the access to other drugs is limited. Let me give you another example. Well, again, this is what we're working on right now. We got a lot of claims and complaints. We're conducting an investigation. Well, the situation is similar. You can see the draft of Russian clinical recommendations, the draft of 2021 on the left, and on the right, international guidelines. For example, the NHS guidelines in the UK. If you can see, if you look at the difference, well, for example, you can see the drug which starts acting, well, 1 minute after the administration, 1 to 10 minutes. Well, here it's from 5 to 15 minutes in terms of dose effect. The only difference here, besides, well, pharmaca indicators, is the presence of nicotinamide. But as for nicotinamide, this drug is beyond any competition. If you look at the procurement of this drug in the regions, we can see that this drug, well, insulin spot plus nicotinamide has a 95% of the market share in a specific region. So you can see the difference can be sometimes from 20 to 40% between this drug and other drugs. And again, you can see there is a real monopoly, and the Russian clinical guidelines do not describe the difference in terms of administration of these two drugs. Let me just give you another example. Semaglutide. This drug was put on the EDL list, essential drug list. It is 20% more expensive than its analogs, and there was a discussion related to international data related to the efficacy of semaglutide. But let me just draw your attention to the fact that regardless of this difference in price, in Russian clinical guidelines, nothing is mentioned in the guidelines concerning this difference. All these three drugs are mentioned one by one, set of by commas, and there is no description of the priority of administration, like what particular drug should be administered in a particular condition. And you can see that right now there is a need to change the situation of putting drugs on essential drug list. Starting from 2018, we just considered the 29% of drugs that were registered for less than 2 years. Now this figure is almost 70%. So you can see that these drugs were put on the EDL without taking into account RWD or RWE. This number increased significantly. We have more drugs on the essential drug list, but without any attention to real world data, and this has a negative impact on the healthcare system. Well, here you can see another example related to insulin glargine and insulin spart. Well, you can see the answer of the authorities that we got. They say that we're not interested in the development of clinical guidelines. We're not interested in the development of algorithms. We're not interested in using RWD. Well, because there is the master file, and any doctor can use a master file for 40 drugs registered for the use against the same indicators. If we look at these three stages of development of the healthcare system, this answer brings us back to stage one, when we just can rely only the clinical thinking, and that's it. Clinical thinking becomes the basis for the development of the healthcare system, which is bad. Here is the international experience. I'm not going to share this experience with you. Let me just say that the Federal Anti-Monopoly Service, when we carry out an investigation and make decisions, we always use international clinical practice for our conclusions. As Mr. Gusev said, that Russia has a low level of trust to information systems that we have right now. We have a low level of trust to statistics, but usually we prefer international experience because it is more reliable and interesting. As for conclusions, I should say that we should develop the Institute of Clinical Guidelines. I disagree with Olga, the previous speaker, who said that we have an ideal model of clinical guidelines. No, it's not like that. Well, clinical guidelines, all the models that we use in clinical guidelines should be based on expertise. They should be real. The question is what particular models we use in the public healthcare system, but the clinical guidelines should not be absolutely ideal. There should be an institute that is involved in assessing RWD. RWD should be written after checking into the clinical guidelines. We've always had discussions on that with the Ministry of Health. And here you can see our proposals on how to use RWD as we develop different lists, such as essential drug lists, as we develop different governmental programs in healthcare. All our proposals are aimed at developing competition, at improving the medical care for our patients. Thank you very much for your attention.